For our next session of the Living Longer workshop, we'll be exploring the issue of intersectionality and aging. In my very first conversation with our first speaker, Karon Phillips of the Trust for America's Health, I realized that there were so many different layers of consideration for the aging population when it comes to not only obviously issues like health, access to transportation, access to services, but when it comes to issues of employment, of staying in the workforce, what supports are there? And then when you add the layer of people of color, people in under-resourced areas and impoverished areas, it becomes a complex issue and one that we journalists really truly need to understand when it comes to covering the older working demographic. So for our first speaker, we'll let Karon talk to us about the issue of intersectionality and aging, how older workers cope with multiple challenges. Karon.
Good morning. Good morning. Thank you all for having me today. It was an honor to be with you today. So my name is Karon Phillips. I'm a policy development manager at Trust for America's Health, and I'll talk to you a little bit about a little background on me. I always like to tell this little nugget. I knew I wanted to work in the field of aging since I was 15. I know I'm rare. I know I come from a long line of educators. We're talking K through 12 educators, and I had an experience. If you want the whole story, my mother likes to tell it better than I do. If you want the whole story, I can tell you, but it was through a volunteer experience. And I just had that rose-tinted glass experience that I knew I wanted to work with older adults. So Trust for America's Health, we're actually not too far from here, is an independent, nonpartisan, public health and prevention-focused organization. We're focused on advancing evidence-based policy and advocacy with a focus on equity. And we are committed to improving the health of every community and making disease prevention a national priority. We produce a lot of reports. We're getting ready to release a report about the state of obesity in the nation later this month. I actually work on a specific project related to age-friendly public health systems. I will weave that in towards the end, but again, our goal in that initiative is to make healthy aging a core priority for all departments of health across the country. So who are older workers? This is some the Bureau of Labor Statistics data. Again, if we start to think about what trends used to look like and what they look like now, they're changing. That's the short of the long. These trends are not the same. So we're seeing a slight increase in the older workforce. Obviously, again, over the past 10, 20, and then even to the next, say what, 8 years. But again, the older workforce is increasing. And civilian labor force participation rates by age. So you have 75 and older. They're not at home. They're still working. And again, the assumption would be, yes, that the 25 to 54 bracket would be the largest, but we still see a high prevalence of the 55 to 74-year-olds still working. So again, what resources and what kinds of supports do they need in this context of intersectionality? I borrowed this chart from a woman, and it talks a lot, it shows a lot. It shows a lot, and I'm going to help pick apart some of this, but the idea of intersectionality and all of these various factors that impact not only just how we conduct ourselves, but our abilities to engage in different environments. And this is not my original chart, so if you want the original, I can point you to the source for this. But again, it's a complex, overlapping, intersecting concepts. We have, again, not just age, but your ethnicity in the workplace. You have your ethnicity and race, again, differing concepts, orientation, physical ability. I'll touch back on that physical ability part again, because I think there's some levels of ableism and stereotypes and assumptions people make about physical ability. Education is a big part of this. And I'll talk a little bit about how exposure in some levels and how just because you were exposed in this way and not exposed in this way, that can impact your interactions in the workplace as well. So unpacking this concept that I'm really going to focus a lot on is ageism. So in my day-to-day role, we talk a lot about ageism, and you would think that in my my however many years it's been at this point, career of working with older adults, that we would have all the right terms, but I know a popular term in the media that we would like to use was the silver tsunami. And we've learned that in ageism training, you do not use that term at all. Do not. Think about what a tsunami is, though. What is a tsunami? Do you want to be associated with something destructive? So thinking about things like I actually also teach part-time, and I spend a lot of time unpacking the term elderly. What do you think of when you think of something that someone that's elderly? You say, I have an elderly coworker. What does that mean? Needs help. Oh, she doesn't know she's elderly. She's elderly. I mean, and that's how, even I'm from the South, your granny's elderly now. That mentality, as opposed to saying, these are older adults. This is the 65 and plus population. So even how we talk to and talk about older people in the workforce, older workers, we have this ever-evolving, ever-prevalent layer of sexism. I don't think I need to go into too much details on that, but that is, again, an overlapping factor. And as I alluded to earlier, this concept of ableism. And I would say it's a little two-sided. We make a lot of assumptions, and I think you all, being journalists, would understand this idea of the generation wars, as I like to call it, where you have, again, as I showed you in the charts, you've got the 55 and up still working, and you have, what are we now, Gen Z and millennials, kind of butting heads on, well, this is how it's done. Well, this is what my training says. But understanding that just because this is how it's done doesn't mean it's wrong, but because it's a new approach doesn't mean it's wrong. But also the assumption that because someone's older, again, going back to that elderly and older coworker mindset, oh, they don't know how to do that. I know I teach a lot, and my students automatically assume, oh, older adults don't use technology. And I said, if the pandemic has taught us nothing, is that at least the older adults knew how to get online and access program resources, because that's where we moved. In the aging sector, that's where the programs pivoted to. So the assumption that a person, we'll say 60 and older, generally we say 65 and older, we'll say 60 and older, cannot do something just because they're older. And then we add in this concept of racism. I think my colleague's going to talk a little bit more about racism than I will, but again, assumptions about inabilities, microaggressions, the assumption that someone is doing something without being fully informed, a lot of assumptions that are carried by sheer assumptions that a person may have about a particular race or ethnic group. So here's the term. And then when we talk about things like anti-aging, why are we anti-aging? We're aging from the time we get here. I'm aging. You're all aging. So again, and it's also remembering that it's not an us and them. It's not the aging population. We're all the aging population. But remembering that it's a part of our population, not an us and them situation. A few little cards for you as we consider older and engagement. Let's see, don't be upset about turning 60. A lot of people are 60. Why, if you were to work, or if you were to take up all the 60-year-olds in the world and lay them to the end, very few of them would, I can't read it, be able to get back up under their own power. 60? But again, these are greeting cards. These are greeting cards. Oh, so then we got the 5 decades. 10, I want a part, I want a pony, I want a drink, I want a raise, I want a vacation. And then you get to 50, you're 50, I hope you just get what you want. I forgot what it is. 50? 50? Again, if we think about you all as journalists and your ability to inform the narrative about not only older adults, but older workers. Again, think about some of the ageist terms and some of the language that you use. So I borrowed these cards from the Reframing Institute of the Gerontological Society of America. They do a great training, and we've supported this training several times. And she has more cards, and I already borrowed these two, but she uses more cards that show just this example of how we communicate about older people, but not even that. Again, we take that and then you bring people into workspaces and you have this notion of, oh, they're older, they don't get it. So again, messaging around older adults in general. Experiences with everyday ageism. 82%, and this again is from a Michigan group. They do a healthy aging poll where they ask a lot of questions and a lot of health-related information. 82% have experienced one or more forms of everyday ageism in their day-to-day lives. Exposure against ageist messages, we just saw some messaging. Ageism in interpersonal interactions. And keep in mind, sometimes there is a little bit of internalized, well, you know, I'm older, I can't do that. You know, that's for you young people, that's this. Anyone know Ernestine Shepard? She is in Baltimore, she's based in Baltimore. She is an 87-year-old bodybuilder. I had the pleasure of being passed by her at the Baltimore Women's Classic many years ago. She ran right on past me. By the time I got there, she had been refreshed and, you know, she was greeting people and I'm like, you know. But again, I always challenge people with that notion of they see Miss Shepard and they assume that she can or cannot do certain things. But Miss Shepard actually started her journey because of her sister and her sister's health. And again, she did not decide to be sedentary. She decided that she wanted to produce another image and show another image. And then again, internalized ageism. That's a big part of this, 36%. I also wanted to just highlight the different changing landscape of the market. How do we match older workers with different skill opportunities? There's opportunities and challenges here. I think it's more of a question than an answer. But if you think about what jobs look like now, they don't look like they did even 20 years ago. The types of jobs are different. The skill sets are different. But how do you even know where to begin? And how do you begin to understand where to match your skills with that? And then there's this idea of cumulative disadvantage. Anyone familiar? I'm getting a little academic on you. I apologize. So the idea of cumulative disadvantage is you start out at a certain point in your life and you acquire, it's cumulative advantage and disadvantage theory, but you acquire certain advantages over life. So if you were exposed to certain opportunities and you were granted certain advantages, you would project it to be at a higher level of advantage in your later years. But if you were at a state of disadvantage, whether it be educational opportunities, health opportunities, even housing opportunities, those put you at a disadvantaged state. So that when you reach older adult age, or when you reach 65 and older, you are at a different state and a different challenge point that if you were not, you might have missed out on other opportunities. So it's a very academic mindset, but if we think about what kinds of opportunities older workers have before they reach, we'll say 60, 65, that influence their opportunities. So Rachel asked me to tell you all things to write about. I could have a list about 100 things, because again, I'm a gerontologist. I could have written a longer list, but I stuck with the 5. So strategies for addressing ageism. I think it's pretty straightforward. I think it's, again, it's multifaceted, not just the communication piece of it, but how people engage with populations. And remember, some of this is internalized ageism. So how do we send messages that it's not just an, oh, I'm older, I can't. Innovative partnerships that provide opportunities for older adults. There are several programs that provide opportunities for older adults to get employment. Some of it's part-time. You know, we've seen different models where greeters are older, but what about other opportunities that leverage experience? So AARP has a great program with Experience Corps where they use older adult workers as volunteers. Expanding on that and offering opportunities to have older adults volunteer or even get more work contribution through providing experience on their leadership. I know a lot of mentorship opportunities come from people that have worked in the field and they can offer their experiences. I worked on Capitol Hill for 4 months. I did not survive. And one of the reasons that I survived for 4 months was because of one of my mentors who was retired. And she gave me all the tips and the nuances that I had no clue about surviving on Capitol Hill. What does it mean to be 65 today? I think that's important because I think, again, that image has shifted. We talked about what an older person really is. 65 is not old. I think we think of 65 as that's the retirement age, but that's not even the case anymore. Some people still continue to work, or if they do, they retire and then they go consult. Contributions across the generations. So again, understanding that every generation has a role in this, in the workplace, but also every group has brought something unique to the workplace. And my fifth and final major point is healthy aging. So healthy aging, again, depicting images of older adults. Actually, there's a couple things. There's new images that different groups have produced that show, like even the little icons we use about older adults. There's no longer the one with the cane. There's ones, with different images that people can use to depict older adults. But how are we depicting healthy aging? And then how are we describing healthy aging? Bringing you a little bit into the age-friendly world, there's a lot of intersecting activities that contribute to age-friendly best practices. So we have age-friendly health systems, age-friendly universities. They're now age-friendly designated employers. These are organizations that apply and they get designated as an age-friendly employer. I work with age-friendly public health systems. Again, this is where we focus on helping local and state departments of health to adopt a healthy aging agenda. And then we have healthy age-friendly cities and communities. I live in Montgomery County. My county is an age-friendly county, but there's also states that are age-friendly. So again, there are opportunities not only in this to highlight how older adults can be supported through these age-friendly initiatives, but also how older adults can, and how employers, cities, and communities can also be a part of the process in helping raise a better framework for age-friendly. That's it. I'm happy to answer lots of questions. I know I brought up a lot of points. I'm excited to hear from my colleague who will be presenting next. My email address is here. I'm around. There's information on our website. Thank you for your time.
All you really need to know about our next speaker is that Gene Axios recommended him. So that should tell you what you're in store for. Brian Smedley is a researcher, senior researcher senior fellow, the Office of Race and Equity Research for the Urban Institute. And in his work, particularly during COVID, he and I discussed some of the findings that he found that not only affect, obviously, issues of health and those impacts of COVID, but he's also going to be telling us a little bit about that 55-plus worker demographic as well and the impact of COVID. So, Brian.
Good morning. Thank you very much for having me here. This has been a really great conversation. I'm sorry I missed the conversation yesterday. So as Rachel said, I've been studying health inequities and primarily physical health inequities, the kinds of health conditions that we think of: diabetes, arthritis, cardiovascular disease, etc. And even though I'm a psychologist by training, I had not studied mental health in particular until COVID came around. COVID obviously posed a lot of risks to a lot of populations, but I was particularly interested in what is the experience from a mental health standpoint of going through the pandemic, particularly for those populations that were perceived to be at risk. And what we learned, I think, is consistent with what we're talking about today, that a lot of our perceptions are based on stereotypes and not a reality. And in fact, what we found is that there is a lot of resilience among older adults, particularly older adults of color. We all know that people of color were hardest hit by COVID and certainly faced higher infection rates, poorer outcomes once sick as a result of many, many factors. But the lesson from COVID, of course, for those of us in public health, is that COVID reflected inequities that existed prior to the virus even coming into our world. The United States is characterized by deep inequities on the basis of income, wealth, race, ethnicity, gender, ability status, age, as we've heard. And so I think one of the lessons from a public health perspective is that inequality kills even without COVID. But once COVID came, the United States had a particularly difficult time relative to other countries in addressing COVID. At one point during the height of the pandemic, with 6% of the world's population, we had nearly 30% of the world's mortality due to COVID. That's pretty striking, particularly when you hear the rhetoric from so many who claim that the United States' healthcare systems are the best in the world. Well, they're not. They are absolutely the most expensive, far and away, per capita healthcare expenditures, easily 2-3 times other wealthy industrialized nations. It's obvious why that is. We consider healthcare a market commodity as opposed to a human right. So all of this baked in inequality prior to COVID coming, we see COVID hitting many communities terribly hard, immigrant communities, people of color, frontline workers, people who had no choice but to get out and interact with the public to do their jobs. And so with my colleagues at the time I was at the American Psychological Association, we wondered what is the experience of older adults of color, a group that is often stigmatized and stereotyped as being vulnerable. And yes, certain populations absolutely were, but when we're talking about that intersection of older adults and people of color, there were a lot of stereotypes and assumptions that we wanted to test. What is the experience that older adults of color had during the pandemic? And I'm going to use the past tense, even though we're not out of the woods, right? So clearly there are many lessons learned. One of the first lessons that I think we learned is that, again, it was not COVID by itself in the US context that made COVID even worse. It was a dual pandemic of racism and the viral pandemic, what some refer to as a syndemic. When you have a population health risk such as a deadly virus exacerbating pre-existing social and economic inequality, that is truly a syndemic. And we have not recovered, right? We still see that many populations that were marginalized prior to the pandemic are faring even worse. And of course, folks with pre-existing chronic conditions had increased risk for poor COVID-19 outcomes, but those prior chronic conditions, again, were the result of social and economic inequality and racism. Structural and institutional and interpersonal racism in particular helped to increase risk for the heavy chronic disease burden that we see in communities of color. So we set about trying to investigate what this relationship is. First, our framework was that the influence of life course experiences, the effects of natural disasters, and chronic stress exposure on the psychological health and well-being of diverse older adults might differ from other populations. So we wanted to understand what those experiences would be. Our first hypothesis was that over time, given the known impacts of chronic stress and disasters, there will be a significant increase in older adults of color's experiences of anxiety and depression and general health. And the second hypothesis was that the increase in reports of anxiety and depression would be worse among older adults of color and inversely related to age, as seen largely among those with significant financial strain and or low income and lower wage occupational fields. So the economic dimension of the COVID pandemic, of course, is critically important. As our previous speakers have noted, many workers of color had no choice but to work or not get paid. And of course, many chose to work to survive. And so that intersection of the occupational segregation that we talked about earlier, racism, ageism, all of these destructive social forces could increase risk for this population. And then finally, we were curious about the relationship between social interaction and mental health. There's prior evidence, of course, suggesting that social interaction, social cohesion, sources of social support can buffer against stress, the kinds of stresses that might be engendered during a pandemic. So these were the questions that we sought to test, and I want to acknowledge the role of the Michigan Center for Urban African American Research in conducting this research using existing data sources. We primarily used the Census Bureau's Household Pulse survey, but sought to supplement that with the National Opinion Research Center COVID Impact Survey. Both of these surveys were designed to rapidly try to understand the experiences of various populations during COVID. We focused on adults 50 years and older, and we focused on the experiences of African Americans, non-Hispanic Asian, and the Latinx population. We also attempted to get a sufficient data sample for the American Indian Alaska Native population, and were able to use other data sources to try to supplement that information. And of course, all of these surveys were administered at different periods during the COVID pandemic. Our focus was on the spring and summer of 2020 to understand what those experiences were. Both the Household Pulse Survey and the NORC survey have specific measures of psychological distress, as well as general health status, asking people to self-report whether their health was fair, poor, or good. It also measured things like anxiety, using commonly asked questions about feeling nervous, not being able to stop or control worrying, questions about depression. Now, these are not clinical indicators, but what they do give us a sense of is self-reported psychological distress that we can assess over time using this cross-sectional panel. So we were first interested in time trends. Over the course of the pandemic, of course, beginning in the spring, March of 2020, you'll recall we all went into, those of us that were able to went into lockdown, those of us that were unable to had to continue to interact in the world. But our hypothesis was that as the pandemic spread and got worse, that anxiety and mental health symptomatology would increase over the course of the summer. And of course, that is what we found. This is probably true for a lot of population groups. We found consistently high rates of mental health symptomatology. Nearly a third of our older adults of color experienced these high rates of symptomatology, but these rates of anxiety and mental health distress were particularly high in the Latinx population, with about 40% of those adults reporting mental health symptomatology. We did see an increase in experiences of distress over the course of the summer. It began to tail off in the early part of the fall following the course of the pandemic, right? We were all getting news reports about increasing mortality rates, infection rates through the summer. As the virus began to ebb in the fall, those symptoms began to go down for our populations. And so that was encouraging to see. But there was a lot of variability in mental and physical health symptomatology based on not just race, ethnicity, and age, but also where one lives. A lot of heterogeneity among these populations. So that's one of the first lessons that we learned, is that it is really difficult to homogenize the experiences of our older adults of color during the pandemic. They varied widely. And what you can see from this slide is that there was considerable geographic variation. When we looked at which adults in which states were experiencing the highest levels of distress and mental health symptomatology, you can see that there were some states that were far to the right. So they were much higher than the average rate of mental distress that we saw. So future research really ought to look into why we saw this geographic variation. Could be due to a lot of reasons. Could be due to differences among populations, differences in migration patterns, for example, for the Latinx population. But it also could be due to different policy approaches that these states took to providing social supports and other services to populations that were critically needed. So look at these states that are on the far right. The first box shows the percentage reporting symptoms of anxiety or depression. The box below that reports the percentage of adults reporting that they were in fair or poor health, and you can see considerable geographic variation. Some states, the levels of mental health symptomatology are 2 to 3 times higher than the lowest states, and we're talking again about the same populations group within the Latinx population, within the non-Hispanic Asian American population, within the non-Hispanic Black population. We saw considerable geographic variation. So future research ought to look into why we saw that significant variation. Again, and very sizable, 2 to 3 times the differences in the level of symptomatology. What this suggested is that a one-size-fits-all policy solution is not likely to be sufficient to alleviate the different experiences of these groups. Second, what did we see when we looked across age groups? Again, this is cross-sectional research. but it speaks to the question of resilience. Did we see increasing symptomatology or decreasing symptomatology as people aged? And what we saw is that the prevalence of anxiety or depression decreased consistently with age. So at 50 years of age, about 40% of our sample reported mental health problems. By age 75, roughly 1 in 4 persons reported mental health symptomatology. And these trends were consistent across all 3 racial and ethnic groups. So what this clearly shows is that notions of frailty as we get older are clearly debunked by these data and likely other data. These adults who were much older were reporting much less mental health symptomatology than those who were closer to the 50-year-old group. We saw a very inequitable distribution of mental and physical health, often linked to meeting basic needs. So when you look at those who reported not having enough food post-COVID, not having enough food pre-COVID, not being confident in their food security or being able to put meals on the table, folks with low incomes, folks who expected a household job loss. These are among the kinds of factors that were associated with increased mental health symptomatology, as you would expect, right? Folks who are struggling to meet basic needs clearly are going to report more distress. And we also see that among those who had higher incomes, among those who had higher levels of education, among those who were confident in their food security, they experienced much less symptomatology than those folks who were vulnerable because of those kinds of social and economic factors. And the same was true for fair and poor health. Those folks who struggled putting food on the table, those folks who struggled with having sufficient income reported higher symptomatology, again, as you would expect. We saw, again, considerable variations in mental health problems within racial and ethnic groups, again, debunking the notion that these are homogeneous populations that we can easily characterize. Basic needs are consistent drivers of elevated mental health problems across racial and ethnic groups, but there's considerable variability even within and between these groups. We looked at the top drivers of mental and general health within racial and ethnic groups. Again, not surprising, the factors that most consistently predicted mental health and general mental health were having food insecurity, income, expected household job loss, less than high school education, and being covered through a public insurance source. So again, these are not surprising and consistent with other literature. I apologize, I know these slides are dense. There's a lot of content in here, so I'm sure we're going to be able to share these slides with folks. We looked at mediators of group differences. Were there factors that helped to mediate that relationship between stressful experiences and health and mental health? And again, found considerable variability with difference in, for example, in prevalence between blacks and Hispanics was 6.2% for anxiety and depression, and it was not differentiable for fair or poor health. Finally, we looked at the role of trust and social connectedness. There's a considerable literature suggesting that in general, trust and social connectedness, social cohesion is a positive good when it comes to a population's health. Those communities that are characterized by high levels of trust and social cohesion tend to be healthier on average. Those communities that are characterized by distrust, such as the United States, and a lack of social connection and cohesiveness, fared poorer during the COVID pandemic. And that was borne out in, except that we found that there was little evidence to support a major role for measures of trust and social connectedness. We need to better understand why we found no relationship here. And it could be, I believe, because as people started to respond to the pandemic, isolating in homes or wherever people could shelter, opportunities for social connectedness, in person or virtual, in many cases declined. And so that social connectedness was seriously disrupted during the COVID pandemic. And so we need to better investigate whether in fact trust and social connectedness had absolutely no role. I suspect it did, because again, there's a strong relationship between these factors and overall health status in the public health literature. So just to quickly summarize, I know this has been a lot of information and dense slides, so I apologize. But important findings for us, again, to both debunk myths about aging, to debunk notions about the homogeneity of various population groups. Overall, older adults of color reported alarmingly high rates of mental health symptoms, a third of the population overall, and as high as 40% in the Latinx population. Mental health challenges increased in the summer of 2020 as COVID spread and began to ease by the late summer and fall of 2020. Mental health symptoms displayed significant geographic variation, as I indicated, with 3 to 4 times more variation across states and even within racial and ethnic groups in terms of mental health symptomatology and health status. Basic needs were consistent drivers of elevated mental health problems across racial and ethnic groups, as you would expect. But resilience against mental health problems comes with aging. Again, 2 in 4 persons age 50 reported mental health problems during the COVID pandemic, but that declined to 1 in 4 by the time we talk about those who are 75 and older. And overall, we found little evidence to support a major role for measures of trust and social connectedness. But again, we need to consider how those powerful protective factors were disrupted during COVID, and how older adults may have used those social connections to restore those protective factors going forward. I will stop here. I look forward to our discussion. Thank you so much.
While we wait for, first of all, are there any questions?
I'm a wellness writer, so I'm going to try really hard not to rapid fire ask you a bunch of questions, and instead you'll probably get flooded in your email. But something I was thinking about and kind of started thinking about when the greeting card went up about if you laid someone who's turning 60, many of them could not get up. Many people, for many reasons of many ages, couldn't get up of their own power if you laid them down. Mm-hmm. And as someone who writes not only about living long, but living well in many senses of the word, I was wondering if you could talk more about aspects of our communities, even outside of the workplace, where maybe for ableism, ageism, we're intentionally or unintentionally blocking people out from living well and living fully. My grandmother was in her 80s and had a Pilates injury and wouldn't rest it because she didn't want the lack of physical ability to be seen as a frailty that mm-hmm. kept her out from the rest of society. And I'm wondering if you guys can speak a little bit to how we can be better inclusive in our communities.
So my mic's still on. Okay. I think, so I'm going to bring you back into public health in my full-time role. One of the key things that we have found with, and it's just kind of a framer, departments of health and the aging sector did not talk, did not collaborate. Fun fact, when I was in grad school, I was the only person interested in aging. And people thought, oh, you want to be a nursing home administrator. Why are you getting an MPH? And I said, I do not want to be a nursing home administrator. I want to go and figure out how to help people live healthier and longer in the communities. So it's taken an effort, it's taken a lot of unique and strategic opportunities for people to convene together. So bringing together the aging sector and public health to have conversations about where are we intersecting, where can we enhance and support the services that we provide to help older adults live longer and healthier. The key thing with public health, and I'm trying to get your question about other places that need to be aware. The key thing with public health is equipped with the ability to communicate public health messaging. So who did we go to when we were looking for information? It was the CDC about COVID. The aging sector is known for their direct understanding of service provision. So linking to people that have, to entities that have expertise in this population and understand that public health, the goal is to promote longevity and to prevent illness. Again, it has led to a lot of unique linkages between providing, for example, vaccines. So I always tell the story about, in Idaho, I do believe, we talk about these older adults who are in rural communities and how are we getting vaccines to them. It took, I think it was, I don't know if it was the fire department, but it took a snow plow, because again, they were rural and they were isolated and they were far. It took the Department of Health, obviously, strategic ways to figure out how to get the vaccines stored and properly transported, and then the aging service sector to understand these are the people that are in our community. So I think, again, public health sector is an example of one place, but I think it also goes, again, to further my life goal of making sure that every Department of Health considers healthy aging a priority. But I think it also goes back to how we educate people about aging. So even that's my other hat. I teach part-time at UMBC and University of Maryland Global Campus, and I spend a lot of time teaching people about older adults in general. So even though we have stereotypes and ageism, if we're teaching public health professionals, if we're teaching social work professionals, if we're teaching any professional really, that's going to at some point interact with older adults, we have to remind them and strengthen them in their knowledge base about healthy aging and understanding what it truly means to be an older adult and not to assume. I actually have a class I'm teaching right now, and the student said, "Oh, can we just speculate on this older adult's health?" I said, "You cannot. You cannot, just because they're 60 and older. Can we just speculate?" And the other concept is understanding that we are living longer with chronic conditions. So let's see, my grandmother passed away last year. She was 92, and she lived a full, rich life. She may have had, I think she had hypertension, but she lived well into her 80s. And again, understanding, to my colleague's point, the aging is not a monolith. We're not all aging the same way, and you do have, again, intersecting concepts that you need to think about. Like, someone once asked me about what African-American older adults like to talk about, and I said, because they were trying to think about programming, and I said, we're not a monolith, it's not a monolith, but remembering that you're going to have to consider not only high-level policy context, but local level context. And I'll stop on the note of one thing is if you go to one community, you go to one community. So older adults are not a monolith, and you have to consider also some of those intersecting concepts of background and race, ethnicity, but also just where they are. Like I'm from Atlanta, so my Southern parents, you can't promote the same type of programming that you would do for. I used to work for affordable housing, and we had communities in Baltimore, DC, Annapolis, and Richmond. One community was one community. So we did not apply the same lens to all of them.
There's an important role for narrative change, and we in public health don't do narrative well. You do narrative extremely well. So the kinds of issues that we're talking about here build a new narrative and replace, dismantle old narratives. We're trying to do the same thing in the racial equity space, where, as a result of our history, as a result of structural racism, all of us carry around narratives in our head, even if we don't agree with them consciously. And so we need to be mindful that if you've been socialized in the United States or other Western societies, you hold negative biases and stereotypes about people who are getting older. And so the way to do that is to consciously begin to dismantle narrative through facts that you all report.
I think there was a conversation with you, Karon, talking about a community where policymakers thought they were doing the residents a favor by putting bikes in. And this was in a community where most of the older workers had to work long hours, 12 hours, and plus they're not going to hop on a bike to go to work anyway. So rather than advocating for a bus route so that these older workers could get to work, they thought they were really doing them a favor by putting these bikes in. So these are the ways that journalists need to look at these kinds of concessions or progress in communities and how they impact older workers. Any other questions here? Let's go over on this side for now. Okay.
Hi, I'm Lauren Mapp at San Diego Union Tribune, and I cover both caregiving and Indigenous communities. My question for you, Brian. So I notice a lot of times when there is research that's published, Native Americans are often left out. Sometimes you see in the news, there's this category of something else instead of, Black, white, Hispanic. There's something else, and that's us. What were your challenges with this study when it comes to reporting mental health on the Native American community during this time?
Oh, I so appreciate that question. So as I indicated, we have data for 3 populations, African American, Asian American, Latinx. We went to several other supplementary sources. There's a supplementary data source for Alaska Natives in Alaska. There's supplementary data sources for American Indians. We were not able to compile the same data, and statistically, the challenge becomes getting the numbers you need to be able to confidently make estimates. But that has been too often a BS excuse. And so what I see researchers doing more these days is to find other scientific methods of producing knowledge rather than just relying on statistical samples and the kinds of things that we get from these large survey data sets like the Census Bureau's Household Pulse Survey. That entails qualitative research, talking to people, understanding their stories and experiences. And so I'm encouraged to see more people in public health and the social sciences generally turning to other qualitative methods of gathering knowledge and information because we have come up short, we have failed. And this is on the federal government in terms of being able to oversample in communities where we know we have consistently lacked data, and that includes the American Indian and Alaska Native population. So if we don't have the sufficient sample sizes, we can't just shrug our shoulders and say we're done. We gotta find other methods, other ways of getting the knowledge to understand the experiences of the population. So I think we're moving in an era where qualitative research is being valued as much as quantitative research to produce that knowledge. And I'd add too, and I don't want to take up a ton of time, the way that we have attempted to categorize and report out racial and ethnic data is so lacking because, again, all of our racial and ethnic populations are deeply heterogeneous. The African American population is characterized by folk native-born, immigrants, folk from Jamaica, folk from Africa, very different life experiences. I would add, some of the data to me suggests that if you are African American and you've been born here in the US, your health outcomes are worse as a result of a lifetime of exposure to racism here in the US than if you were Caribbean born or African born. So we need to do a better job of disaggregating our data.
I'm Alexa. I'm with Fortune and also in the health and wellness space. And Karon, I thought it was interesting when you were talking about kind of this term anti-aging when that doesn't make sense because everyone is aging. And I think in the wellness space as well, there's a lot around this anti-aging topic versus aging well. And you also talked about language when thinking about even those cards. And I think that struck me too. So I'm curious when thinking about reporting and writing in a way that's inclusive and that isn't talking about anti-aging. I'm curious your thoughts on language with reporters and inclusive language. I think we've talked about that a little bit here. Thinking about reporting on different generations. And so I'm just curious if you both want to touch on language that is most inclusive as reporters to keep in mind when reporting on aging.
Part of that is the idea of aging based on a biomedical model as opposed to the biosocial model of you can still age well and have a chronic condition. You can still live a full life and have comorbid conditions, but the goal is healthy aging. I think that would be my default go-to is the idea of preventative and self-management and making sure that you're taking care of yourself in that space that you're in. So focusing less on the old, and again, I think we're still there, focusing on the biological definition of health in general, and focusing on healthy aging and wellness is another word. That gets at the idea of not just focusing on being disease-free. I think that is still but if you're disease-free, that means you're going to age well. It's like, actually, I had a student write, chronic conditions is a sign of poor aging. And I said, you can have a chronic condition as a child, so that's not the proper thought process. But again, the idea of healthy aging and wellness as we age, and again, stepping away from that biomedical mindset, I think. I don't know if you want to add anything.
I completely agree. I mean, and it's hard to get out of it. Again, this is we're trying to cleanse our minds of the way that we've been socialized and raised to believe in, and it's so subtle. But the imprint of society is in our unconscious mind for all of us. And so the societal level biases and attitudes that we're struggling so hard against, I don't have specific language to recommend to journalists to be more inclusive. I think you're using some of that language here. I'm hearing great examples of people pushing back against even stuff that we might say casually that helps to perpetuate stereotypes. So to me, again, it's about that narrative and trying to really reveal the imprint of society on our unconscious minds.
And again, they do not pay me for this, but I will refer you to the Reframing Aging. It's actually a center for reframing aging, and they have tools, like toolkits that tell you that is specifically for writing and communication, and we work with them a lot.
Where are they based?
They're based here, so they're based as part of the Gerontological Society of America. I promise you. Center for Reframing Aging. They just became a center. And they have toolkits, and again, we engage with them a lot on not only, actually we host a training every January through my initiative at TIFA, but we're also getting our staff trained on ageism, because we have a staff, section of our organization that goes out and does government relations. So how are they communicating to our legislators about older adults? And we have a staff that does research and communications. How are they communicating about older adults? So our whole staff is getting ready to go an ageism training sponsored by Reframing Aging.
We can take one more question.
Anitra Johnson, Delaware Online and News Journal. And my question is for Brian. Actually, I have two. If you could explain, the chart says something about high rates of mental health symptoms, but at the same time, there's high rates of resilience against mental health problems. If you could just explain that. But going back to the reports of mental health problems with African Americans, and I wanted to ask, how does mistrust of the medical community account for or impact those numbers if there are lower rates of reported mental health, but also high mistrust of the medical community? So if you could explain that.
Sure. So the first question was about why am I saying that as our research indicates that older adults show resiliency against mental distress. So our data is specifically around symptoms of anxiety and depression. We saw higher rates of that mental distress symptomatology in the 50-year-old, 50, 55, 50 to 60 range. Those rates declined as people got older, suggesting to our research team that as folk get older, they are resilient. They are likely drawing on life experience and other sources of social support to cope in an extremely challenging time. Specifically to African Americans, to me the issue is trustworthiness. Too long we have talked about, well, black folks don't trust the health system. What health systems are trustworthy? What health systems are showing evidence that there's no racism in their health systems, that we are producing positive outcomes for every patient, regardless of their race or ethnicity? So I'd like to turn that question on its head. It's so interesting to me that people talk about, and particularly during COVID, there was a lot of conversation about people of color, African Americans in particular, not trusting the health system. Well, of course, that's for good reason, but then at the end of the day, we saw vaccination rates about as high for African Americans as other populations. So the question to me is, what can institutions do to be trustworthy, particularly our healthcare systems that do have a long history of inequitable treatment on the basis of race? So I think that remains a significant challenge. The only way to become trustworthy, I think, is to show that you are producing positive outcomes regardless of race or ethnicity. The only way to do that is to collect the data and prove it and publicly report it.
I think that's a powerful note to end on, this issue of resilience. And certainly as we think of, again, ongoing discussions about how we characterize the older worker, We have to keep that in mind. The underlying strengths, the underlying coping mechanisms, and for those who work because they want to work, and not just capturing everyone as big victims of this. So I want to take this opportunity to personally thank Karon and Brian for their presentation, because it's really helped deepen my own sense of understanding intersectionality in general, but certainly for this group. So let's all give them a round of applause.